Hello, everybody. Welcome back to another episode of The Root of the Matter. I am your host, Dr. Rachel Carver, and I'm very pleased to introduce to you guys Dr. Jessica Lee, who is a double board certified ENT or ear, nose, and throat doctor. She's got a focus in integrative medicine too. So, of course, I latched right onto her, and her reading her website or bio really resonated with me because, like me, she has that curious mind and always wants to learn more. Why is certain things happening? And I reached out to Dr. Lee because I see all sorts of things when I take my 3D cone beam x-rays. Some patients may have certain symptoms, and I'm always curious what's going on. I've never been able to really find the answers. So I found the person who could provide us with those answers today. Dr. Lee, thanks so much for coming on. Maybe introduce yourself, tell us a little bit about how you got to on your path.
Great. First, thanks for having me. I was honestly so tickled when you reached out, and I love this. I love collaborating. I love learning from other colleagues. It's this strange world we live in where dental medicine and other medicine is separate, but it really shouldn't be. And so I've really enjoyed learning from you, learning from other dental specialists, and I think it's great when we work together. So I'm happy to be here. I am, like you said, double board certified. I am primarily trained first as an ENT surgeon. So I did medical school and then did a 5-year residency, and I've been out in practice for over 10 years now. But really, starting at the end of my residency, I was already starting to just have these questions of, hang on, like, why does this happen? And how come this happens to some patients and not others? And we had a personal situation in our family with one of our kids' health where we actually ended up treating her problem with a dietary modification. It just was like a light bulb went off because people are often like, where did this start for you? And I'm like, honestly, that was the moment it started. Because I realized nowhere in medical school or residency training did anyone tell me about the power of food as medicine. And then I had witnessed it in a miraculous way with my daughter. And so that was like the spark that was thrown into the patch of sticks, right? And from there, I've learned more on my own. I ended up getting a second board certification in lifestyle medicine, which really focuses on trying to treat and prevent chronic illness by modulating nutrition and exercise and sleep and toxin exposures and stress management and personal connections. And then from there, I keep, like I said, I keep being more curious and I keep learning more. I've taken herbalism medicine classes. I've taken classes on mold illness. And like I said, I just keep wanting to learn more so that I can put together what I learn and take it back to the patients I'm seeing. And in some ways, just feel like I have a better breadth of options to discuss and treat with them.
I think we talk about that a lot about what's in your toolbox, right? A conventional dentist or maybe a conventional MD has this tiny little closed off box, right? And then when you start learning all these other things, it's just like our toolboxes expand, right? Because it's not to say what's in those small little conventional boxes are wrong or not good, because obviously they're fantastic and we need those kind of things. But when we get into these diseases, like these chronic issues, that little box doesn't hack it, right? It's not enough to really uproot all the causes that we see in our society today, where we just have an explosion of all these chronic issues, which I think most people are really awakening to the fact that they are lifestyle issues. And I think the challenge is most of us know we probably shouldn't eat McDonald's every single day. But we do because why? Because we're tired, we're stressed, we don't have time, all these kind of things. And again, when we take that whole kind of holistic WH look at life, it's why are you stressed? Because the more I practice and the more I get into that kind of energy and the emotional space, it's like these things about not having time. And while they may be true, sometimes they're excuses because we're pushing down some of the other root causes that are allowing us to feel more stressed. We can go down that rabbit path.
Yeah, no, to me, the ultimate definition of integrative is it's both toolboxes, right? It's not just conventional medicine toolbox, and it's not just complementary or alternative medicine. It's the combination. And that's where I think, at least in my practice, my patients see the most success is when we're putting together. And a lot of times you can alter how much of one or the other you use based on how much modification, like you said, you want to do to your lifestyle.
Right. And that's so important because every person, I think sometimes where conventional medicine can fail, like in the example of prescription meds, is that we're giving everybody with a similar symptom the same drug, but every person is unique. And so that's where that integrative, they're throwing around the word personalized medicine now, but it's really true. We're all very different. And I've taught people who've worked with me, remember, you're treating a person, not a tooth, because you could have 4 different treatment plans for the same kind of tooth situation, but you have to take into consideration that person, right? So that's, I think, that value in mixing both of them. And sometimes when I first went down on the path, I eschewed conventional medicine like almost 90%. I was like, no, it's just all bad. But then as you're working, you're like, well, that's not true. Sometimes I need these. And in my patients, we're like, oh, sometimes the combination of ozone and antibiotics works better than just ozone. And even in my own daughter, she was coming down, she had just this horrible breath and like her mouth was fine. I was like, there's something in her gut. Something is just brewing there. And when she ended up coming down with a pneumonia, she didn't have the symptoms of pneumonia, but I took her and had some blood work done. One of the bacteria. And I was like, you know what? I got to nuke it. I got to nuke it and start over. And so I did. I gave her the antibiotics. And probably a year ago, I would have been like, never will I give my child it. But it did what it needed to do. Like it completely eradicated whatever was brewing in there. She hasn't had that since. And then just I'm building her back with the right probiotics. And she's a teenager, so trying to get her to eat better is a challenge. But I was like, and the reason why I decided to do that is because I had a patient come to me. She had a dental infection. I had given her antibiotics, and she said, you know what? That really resolved a lot of my gut issues too. And I was like, okay, all right. Be open mind. It really just gave me pause. And I was like, okay, yes, we need that combination, right? We live and learn, and and I think that's what's so valuable about working with patients and learning from each other, because sometimes we can get stuck in our ways. And maybe for the betterment of all of our patients, having that open mind, I think, is really valuable.
I think that's the key. It's open mind, it's curiosity, it's a healthy amount of skepticism.
Yeah.
And it's the conversation with the patient. Like you said, it's just sitting down and saying, look, this is what the evidence shows. Let's talk about what you want to prioritize, and then let's come up with a treatment plan that we both feel comfortable with.
Yeah, I think that's great. And sometimes I don't really know. Like sometimes we'll come in with a problem, and I'm like, with all my training, like I can't see what the problem is. And my first question will be, what do you think is wrong?
Yeah.
Patients are like, they're living in their own body, because I'm like, okay, what are you feeling? I think we've lost so much of our intuition. And so I'm like, really tap in. What are you thinking is? I had one the other day, and he's like, I have an abscess, and my hygienist was evaluating him, and she said, I don't think he has an abscess. And I said, what is he saying? And she said, he's really determined. And I said, well, then take an x-ray. And sure enough, he had an abscess, even though there were no clinical signs. Right. Yeah, I was like, see, we got to believe that the patient, and that's interesting. Let's get into the ENT stuff. So I think one of my biggest questions always is, especially in the last, I don't know, maybe 5 to 10 years, I just see so many cases of swollen tonsils. And I'm always trying to figure that out. Is it their breathing? Or do they have a food allergy? So maybe talk to us about some of the common causes of swollen tonsils.
Yeah, that's a great place to start, because so many parents with kids, obviously, will come in with that same question. And I got a lot of referrals from dental practices in town with just, hey, they have big tonsils. Should we do anything? Right. And I think the first thing I do is explain that your tonsils are just one type of tonsil, but we refer to them as tonsils. But really, you're referring to, I think, the palatine tonsils, which are the ones that sit on the sides of our throat towards the back of the throat. Those are the ones you could open your mouth and see. You also have tonsils on the back of your nose called your adenoids. And you actually also develop tonsils on the back of your tongue called lingual tonsils. And they form literally a ring. It's called Waldeyer's ring. And that is like your first defense mechanism. So as we are developing and growing, we're little babies. Think about it. Babies are putting everything in their mouths. They're breathing in all of these things that their body has never seen before. And so this ring of tissue is part of the immune system, and it is primarily responsible for teaching the body what do we need to be concerned about and learn to fight against with antibodies versus what is just normal, right? So that's going to be the things you're inhaling in the air, like dust and animal dander and pollens, and that's potentially chemicals, right? It's also going to be all the foods that they eat, and it's going to be everything because, again, kids are very oral and they're testing the world with their mouth, right? So that said, this tissue serves a very important purpose. Now, what can happen is if that stimulation is like a tsunami wave, then you will sometimes get very rapid growth of those tissues, and it can reach a point where it causes a functional problem. So the tonsil tissues, and I'm going to group them together, but I know we're referring to the ones people see in the back of their throat. Those typically are going to start to grow bigger around age 3, and that growth goes on for about 5 years. So between the ages of 3 and 8 is when those tonsils tend to be the largest. And I would say the adenoids, which are the ones in the back of the nose, they're probably more like 3 to 6 years old. That's the active growth phase. So when I'm seeing a child who is 3 or 5 and they have larger tonsils, I'm saying, okay, that's not all that unexpected for this age group. But the question is it causing a problem? And so then that's where we go into asking parents about their breathing patterns. Like you mentioned, am I noticing while I'm talking to mom and dad, is the child sitting in the exam chair with their mouth hanging open and just constantly breathing through their mouth? Because that's a flag for me, right? We're asking about strep throat infections. We're asking about how many times of the year they get sick with kind of cold symptoms, allergy symptoms, right? All of these things, food sensitivities, all of these things can play a role in those tissues maybe potentially getting so big that they're actually causing a problem. And that leads us into kind of treatment option discussions.
What about the adult who says, I've heard this multiple times, they've always been large. So, at that 8 years old, do they tend to shrink back down? Or because why does somebody who's 40 years old have is in a chronic situation, or is that their anatomy? I never really know what to say when somebody says that because I think, well, but not everybody has big tonsils like that. But
yeah, so you're right. So that active growth phase kind of ends around 6, 7, 8 years old. And then there's just a stagnation period where the tissues stay the same size, but you remember that the person, the body, is getting bigger. So there can be a relative decrease in how much space that tissue takes up because they stop growing, but the rest of you keeps growing. Then when you're in your kind of teenager, early adulthood years is when we really start to see the tissues shrinking. So it's called involution. But again, remember this tissue's primary job was to teach your body. And by the time you're about 20 years old, you've pretty much been exposed to most of the things you're going to be exposed to in life, right? So we don't really have to rely on that tissue as much. So it does start to shrink away to the point where I have people in their older decades of life whose tonsils are so small that even myself as a trained professional looking in their throat, I'm like looking and I'm like, did you have your tonsils out? And they're like, no. And I'm like, okay, they just shrunk like pretty much all the way. So now that's the expected course. But you're right. You're going to meet someone who they are in their 40s or 50s and they've got like big tonsils. And I would say that's not the norm. I would say that's the exception. And again, my questions then are, is it causing a functional problem? Are you having recurrent infections? Are you having chronic inflammatory symptoms due to it? Are you having sleep or breathing problems because of it?
And so let's say we rule out the breathing stuff and you're concerned, like, is there some mild chronic inflammation? What would you do to investigate that further?
So obviously we always start, like you said, we got to talk to the patient. We got to see what their body feels like. I want them to be aware of what their body feels like and hear from them. And we just take a really good history to look at, is this something that occurs with seasons of the year, or is it something that's year round? Is it occurring mostly when you're sick with a viral upper respiratory illness, or is it happening completely randomly? And what are those symptoms? There are a lot of, remember the throat, that place in your body is an intersection between the upper airway, so the nose and sinus cavities, the mouth, so everything going in your mouth, and then from below, like lungs, esophagus, and GI tract. So when someone comes in with a sore throat, I have to think of all those different things as potentially being contributing factors. So we start going through it, right? We start asking all the questions about Do you have nasal itching, sneezing, runny nose, congestion? Do you have reflux or laryngopharyngeal reflux symptoms? Do you have any history of asthma? Are you having infections? There's a lot to cover when it's assessing for that. But I think that's the point, right? If you just say, this person's having chronic sore throats, let's take their tonsils out. Well, but like your name of your podcast, if that's not really the root cause, then they may continue to have symptoms even once that tissue's gone. So I always think it's important to try to find the reason. And sometimes we can treat it without surgery.
Mhm.
And obviously, like we said, in some cases, surgery is a very good option.
Yeah. I know there were some studies that were showing that removing of the tonsils in children might not be the perfect solution. And I don't know if that's because those are really airway cases and really we need to grow the jaws. Like just removing that tissue doesn't really solve the problem. I don't know. Can you talk a little bit about why those studies were showing that?
Yeah. So I think you're referring to specifically like the obstructive sleep apnea kids, or even just the precursor, which we call sleep disordered breathing. Those kids, there's been some studies that say, okay, we took their tonsils out. 30% of them still had sleep apnea afterwards. So why was that? And you're exactly right. This is where this collaboration and this multidisciplinary approach is so paramount, because those kids not only had large tonsils and adenoids, but they probably also had maxillary deficiency, right? Maybe their upper jaw was a little too small or a little too narrow. And so the growth pattern of their face and their facial skeleton has put them in a position where it's not just treat one thing, it's look at the big picture. How do we help a little bit here, help a little bit there, help a little bit down here? And then at the end of the day, we've optimized not only their craniofacial growth, but also their airway.
And I love that because I think sometimes, again, depending on our experience and our expertise, we're looking at what we know and we're forgetting everything else. I was just talking to you earlier about my vision training, right? One of my eyes was like ignoring, or my part of my brain was ignoring stuff that my eye was seeing. So in the same way that we're not trying to, but again, based on our own experiences, we can miss these things. And that's what I see about 90% of people have a deficient maxilla. Like none of us are really growing wide enough or forward enough. So that's the upper jaw we're talking about. So when the upper jaw doesn't expand or move forward, then that lower jaw is trapped. Most of the time, our upper jaw overlaps the lower jaw. And so then that lower jaw remains posterior. There's also the tongue, right? If we didn't, sometimes with breastfeeding, that actually is, you're training the tongue how to have suction up at the roof of the mouth because it's the tongue's job to create that width in the maxilla and help push it forward. So if that tongue isn't going on the roof of the mouth and pushing it forward, we have like lazy tongue or a tongue thrust or something like that. That's another issue we have. So again, it's like looking. This is why I always get frustrated sometimes with conventional orthodontics, because we just look at the teeth and we make the teeth straight, but we ignore all the reasons why they became crooked in the first place. And if we don't really do the expansion and train the tongue where it's supposed to be, we often get relapse and sometimes even joint issues because we move the teeth in a way that the body had already adapted, right? They became crooked because the body was like, this is where I feel comfortable. Right? And then we artificially move it back with braces, and then everything else has to then maladapt in another way. And we'll get into all the fashion. We talked about that on an earlier podcast. That's the big thing. And what's so important, especially for dentists, we ideally want to see kids at age 1. We can identify these things at a very early age. And so you can get that interceptive treatment, the myofunctional therapy. We have all sorts of cool little guards and all that. And man, when those kids are compliant, it works so well and so fast. It's so satisfying to see that. One of my office manager's granddaughter, she was frustrated. She, at 10 years old, was like, I don't like this. There's something wrong with my mouth. Help me out. And we just put her in expanders in 3 months. And she's so proud of herself. That's what's so exciting, right? Because she took it upon herself to be like, Grandma, I want help. Can you help me? And so we brought her in, and just with these expanders, it was so amazing to see her teeth, everything just widen right up, her breathing, just super exciting.
It is. It's very cool. I have to give like a shout out to the dental specialists here and the orthodontic specialists that I collaborate with, because I am lucky that we have a group here in Charleston who this is what we do. Like we meet and we teach each other. Like I've learned so much more about maxillary deficiency, which really isn't a term that we use a lot in the ENT residency, right? But then they've also learned so much about like the adenoids and the tonsils and other things that can cause airway inflammation and cause trouble with the airway. So it's been, I think you cannot go wrong if you're working with a provider who is in one of these kind of multidisciplinary groups, whether it's
100%.
formal or informal.
Absolutely. Absolutely. Like I said, we all have our focus of expertise, but there's so much more beyond. And when we start to put the whole body back together again, we're like, that's so great. So I was just talking to a colleague who works at Harvard Medical School, and we're been talking to him about helping teach these kids this whole big interdisciplinary approach. And I say, Harvard is poised in a great position because you have the medical and dental students right there. So if we can start them collaborating at the very beginning, we're gonna have so much more success in all fields of medicine and dentistry. So, fingers crossed. We'll see what comes of that. But so let's talk a little bit about the other big thing we see a lot is tonsil stones. So tell us a little bit about what that is. What are
tonsil stones? They are the bane of everyone's existence if you have them. They are so frustrating. And I know patients come in and they're done with it. So tonsil stones are truly little pieces of material that are in your tonsil. We call it a stone because it really does calcify like a stone. It is typically a result of, it's never one thing, is it? It's a result of the shrinkage of the tonsils. So we did talk about how those tonsils will shrink away as we get older. So while I will very rarely see tonsil stones in kids, tonsil stones are usually an adult problem. Because as that tonsil shrivels, I tell people, think about a grape and how it shrivels down to a raisin. That's what your tonsils are doing. So now you've got all these little furrows and pockets and crypts that can collect food debris. So if you're eating and your mouth is mixing all the saliva and you're swallowing and there's little bits of food debris that get in there, okay, so that's like step number one. Step number two is dependent on the microbiome in your oral cavity and your oropharynx. And if there's a predominance of certain types of bacteria, then you are more likely to get tonsil stones. And then they start to make their way out, right? Which is where people start to feel them. It can feel like a popcorn kernel stuck in the back of your throat. It can be really agitating. And then, of course, if you are lucky enough to get one out, you will often smell a really foul odor associated with it. That's the sulfur. That's actually part of that back to the microbiome. It's a sulfur compound that you're smelling. So for better or worse, the fast answer of how to deal with tonsil stones is remove the tonsil. Now, do I recommend that to everybody that walks in the door? Absolutely not. Because I also have seen that some people get tonsil stones in waves. Some people get one batch of them and never get them again. Some people get them and get them their whole life. And so I think you have to, if someone comes in and said, I'm just started getting these 2 weeks ago, I'm going to be like, look, let's talk about all the different things that can make it easier to manage them. But it is very possible that these are not going to be a lifelong thing for you. So we don't really jump. Tonsillectomy is out there as an option, but it's not the first thing I jump to. I always talk about dental hygiene. Most people, by the time they're coming in to see me, they already do that. They're already brushing and flossing and using a mouthwash. Even just, I tell people, literally gargling with water after each meal, like just something to mechanically remove that food debris. It doesn't have to be medicated. Even just gargling with water is really helpful to prevent it.
So do you know what the species are that are more common in people with tonsil stones?
It's not clear, to be honest. The most common species, the most prevalent species in our throat are obviously streptococcal. So people think of strep as bad, like strep throat, but there's plenty of different types of streptococcal bacteria that live in our throat that are actually very helpful to us. And so even in patients with tonsil stones, that remains the most common. So we don't have as much information to say, I guess what I mean is there's not enough information to manipulate yet. You know what I mean?
And oral saliva tests are becoming more and more popular. So I'm just curious. Right. We do a couple, it'd be nice to see a study on everybody with tonsil stones. Let's just do the oral saliva test, and that would give us, and maybe that's been done. I don't know if that's going to make me go search PubMed later. But yeah, because that's a really good first step, I think. Say, hey, why don't you go get one of these saliva tests? Because if it's a certain type of bacteria, then your dentist, especially if you have more of a biologic, or you have a health coach or a nutrition specialist, we can try to figure out how can we change that microbiome so it doesn't keep happening, because that versus surgery is a little less invasive.
Right.
And so like we always know we can go to surgery, but also if that's a sign that the oral microbiome is off, what other things could be happening? Because if we're swallowing that all the time, that could lead to other gut issues as well.
Yeah. And that's a lot of the kind of next step of, again, I talk with patients about gut health and reflux disease and how that can impact even up into the throat. Interestingly, talking about like microbiome and strep and tonsils, so there are plenty of studies that will support the use of a certain type of probiotic strain of strep to prevent strep throat. And I don't know if you're familiar with it, but it's strep K12. And I will tell you that personally, I've started recommending that as a first step before recommending tonsillectomy for a lot of people with recurrent strep. And I've had the vast majority of people not need to come back for tonsillectomy. And so you will find there's case studies and systematic reviews, and it does seem to be helpful in reducing the incidence. So it's very exciting because, like you said, we don't quite have that enough information to do that for stones, but I think that's in the future. I think that's coming.
Yeah, definitely. And speaking of strep, I've read some studies and heard people talking on other podcasts about chronic strep being related to mold sensitivity and mold infestation in the sinuses. I don't know if you're familiar with any of that and how that could be connected.
In general, when you are in that world and talking about mold illness and things like that and mold exposures, the bottom line is chronic mold exposure will put your body into a state of slight immunosuppression is how it works. And so if that's the case, then any slightly pathogenic bacteria, so any bacteria that could cause a problem in your body has a better opportunity to cause a problem. Yeah. So again, we all have the strep bug that causes strep throat. We all have it in our system. It's just a matter of whether or not the rest of that microbiome is keeping it in check. And so then if you add in something like mold exposures where someone's slightly immunocompromised, now you've given that strep the opportunity to cause a problem.
Yeah. And I think that's really important that we are starting to realize more and more when we study all these microbiomes throughout the body is that we've got to get away from the idea of trying to kill everything that we think is bad and actually supporting the environment so everything's in balance.
Agreed.
Like we talk about in the oral bacteria, there are certain, like we call them red type bacteria and certain species that are so bad, but they're present in health. Yeah. It's just the numbers, right? What in the environment, like you said, is there molds? Is there what other toxin is creating this poor environment that's allowing them to become pathogenic? Because it's also interesting, certain different species of bacteria, right? So there was an article from this oral saliva test. Bristol Health is the one that I use a lot. And they were talking about a specific, now it's going to go out of my brain, but a specific type of bacteria found in the mouth that they were saying can cause colon cancer. Oh, Fusobacterium nuclei. Yeah. But it was only a subset of the Fusobacterium nucleatum. Only one strain, so not all Fusobacterium. So that's also where we got to be careful with some of these saliva tests too. Exactly which strain are you testing for? Because not all of them are bad. It might just be one subset there. So again, it's really interesting. And the nuances of the microbiome are what's the challenge and why there's so much research surrounding that, which is really exciting. And I think when we start to learn our own genetics and our own, there's so much easy way of testing our microbiomes nowadays that's how we can really get into that unique personalized treatment for a lot of people. So I think that's certainly, and then with AI coming in, that certainly gives me that.
I mean, we are on the frontier of something, and we'll see what it looks like in 10 more years,
Exactly.
But it's very interesting.
Let's move on to the sinuses. So we talked about this when I first contacted you, because I'm like, I take these 3D x-rays and sometimes you see like almost like a lake in there, right? So it's just fluid that maybe is filling part of one or both sinuses. Sometimes I see a polyp that almost looks like a mushroom cloud, and you see that in some areas. So maybe talk to me about, and most of the time, I would say 99% of the time, the patient feels nothing. They have no idea that there's something going on. And so my first question is always, have you recently been ill? Because if we've had any kind of upper respiratory infection, yeah, our sinus may be full. And that's usually when we see, I guess not always, but sometimes we see more of a symmetrical kind of fluid base there. But I'm always curious about that, but those little weird polyps things. I'm like, what is that? Could that be there? Is that a problem?
It's the joy of the incidental finding, right? Where you're like, now we got to track that down. Yeah. So with sinuses and sinus findings, there's a pretty easy mnemonic that we learn in residency that is the first thing we think about. So it's FMEN. It's FMEN, and it stands for fungal, mucosal, encephalocele, or neoplasm. And that's like the thing you think about if you have a diseased sinus, right? Now, if you have diffuse, like if all the sinuses are in gray, which means that they have a lot of mucosal thickening or maybe some actual fluid in there, you're going to think more along the lines of like chronic sinusitis, allergic rhinosinusitis, eosinophilic disease, things like that. But if it's just for you guys with CBCTs in office now, a lot of times, again, people will come to me with their CBCT scan, and all we see really is the maxillaries mostly. And you'll just see, like you said, a little mushroom, like a little bump. And people are like, what is that? Do I need to worry about it? So that's most often what we call a mucosal or mucus retention cyst. And the vast majority of these are going to be asymptomatic and they are benign. They are the result of blockage of a mucus gland, probably from some irritation in the past, right? It could have been weeks ago. It could have been years ago. We don't know unless we have a previous scan to compare it to. But in general, think of it like a little mucus bubble. And if the patient is completely asymptomatic, and if there is no sign that it's going to cause any other problems, and I'll come back to that, then generally I tell people, this is not something you need to worry about. We're not gonna do anything. Now, that said, if these mucus bubbles get so big that they fill the entire sinus, then usually those patients are going to have some symptoms, mostly pressure, maybe some even eye pressure, discomfort. They may start to have sinus infections because it's blocking the natural drainage pathways. So those are times where I say, okay, we probably are going to have to do something surgical for this. So that's the most common thing. That's the little mushroom thing. You mentioned like it sometimes looks like a lake where there's like almost a straight line and it's gray below and black above. And that's because it is an air fluid level is what that's called. So again, if someone's sitting upright at a chair and we scan their face and there's fluid in the pocket of their sinus, then you're going to see that kind of lake appearance. The difference I often tell people is if you're getting a CT scan where you're flat on your back and you're going through the scanner, then that air fluid level is going to look like it's up against the back wall of your sinus because gravity is going to pull it that way. So those are usually findings of fluid in the sinus, and that's most commonly going to be pus. So you're right. It's going to be someone who is either actively sick or was recently sick. Usually on nasal endoscopy, if they're coming into clinic, I'll do a nasal endoscopy exam, which is a camera exam. And usually we can see like a stream of pus and mucus streaming out of the sinus and into the back of the nose in those cases.
Sounds delicious.
Let's see the joys of being an ENT, right?
Yeah.
Snot and pus and all and spit. And all this.
Yeah.
Right.
We see all that good stuff in the mouth too sometimes.
Right.
Oh, and we're weird, right? Because we're like, oh, that's so cool. Look at this.
It's so satisfying when it's better too.
Yeah. And we get mucosals a lot of times, like on the inner part of our lips. I got them all the time when I was pregnant. I don't know why. I never had them before. Haven't had them since. And usually we can bite them and break them and they can go away. You can't really do the same when it's up in your sinus, but that's good to know. So some kind of, and the body sometimes uses mucus, right, to wall off a toxin or something like, I think this cysts are even like fibrolas and fibroids in the uterus. These are all kind of ways of walling something off to protect the body. So I always find that kind of fascinating. What was the E that you mentioned in your mnemonic?
Yeah, so encephalocele. So you're not going to see that in the cheek sinus, like from a dental scan, but in the full CT sinuses, that's something that we think of if we're seeing like ethmoid region or sphenoid region, which is up near the part of the skull that separates brain from the sinuses. But the other one I want to bring up, because you did mention like walling off, so this is a good time to talk about it. So the F, right, was fungus. And so I have seen patients come in with dental scans and they have just this mass of gray in one of their cheek sinuses. But there's sometimes little clues, like if there's bright white spots inside of the gray, that can be calcified material. And that can be an indication of fungal disease. So usually these are called fungal balls or mycotomas is what they're called. And patients can be completely asymptomatic and have a huge one sitting in their sinus because, like you just said, I think the body is trying to wall it off and to protect the rest of the body. Now, in some cases, it's successful, but in some cases, it's not. And it will actually start to stimulate more secondary bacterial sinus infections. And that's when patients become aware of it symptomatically. And then in those cases, we have obviously treatment options. But yeah.
For stuff like that, are you using like antifungal nasal sprays, or is that something where you can give the oral and that will take care of it?
So for fungal balls, you have to surgically remove them because there is a physical presence of an irritant and you have to remove the irritant. So antifungals don't work. So antifungal nasal sprays, the point to remember with that is it's not going to reach your sinus.
Right.
So if you're using an antifungal nasal spray for some type of intranasal thing, then that's potentially okay. But it's not going to go into the sinus because the nasal cavities are very narrow and slightly tortuous. And if someone's never had sinus surgery, their sinus openings are sometimes 1 millimeter or 2 millimeters in size and off to the side or up to the top or way at the back.
So thinking about that, we have like neti pots and all these kind of nasal lavage is a big popular one. But is that really getting into those cheek sinuses?
So if you've never had sinus surgery, the chances it is not getting into your sinuses. But it's still extremely helpful. Like I'm a big fan of saline rinsing because again, a lot of the mucus that people are having problems with, that they're symptomatic from, it's coming from one of two places. It's either coming from the mucosal tissues in the nose, so most specifically the turbinates, and those have a lot of mucus glands, which again, rinsing that area, which you are going to reach with the saline rinse, is going to be beneficial. But even if it's a sinus issue, I will still recommend rinsing because remember I said sometimes I'll see that little stream coming out. We want to keep that pathway open. And the longer a thick, purulent drainage sits there, the more swollen that opening gets, and the opening will sometimes just completely swell shut. And now we have like a stagnant sinus infection with no way to drain. So I tell people, even if we see a sinus infection, we see sinus drainage, if you keep those saline rinses going, you're going to encourage that flow so that the hole stays open and the sinus is able to exit all of the stuff it needs to get rid of.
So do you recommend, as a preventative, we're in springtime now, the pollen counts have been crazy high here in Massachusetts this year. I don't know if it's elsewhere, but so somebody who maybe has seasonal allergies, is this something you recommend maybe they did once a week, or what are your general recommendations?
Yeah, absolutely. Because again, back to that first cause, which is that it's really intranasal mucus that bothers people, especially with allergies. So absolutely, if you have seasonal allergies, incorporate a saline rinse into your regimen during that time of the year where you're bothered by it. Especially if I will tell people when they have grass allergies that are really bad, if you are out and you're mowing your yard and you come inside, you want to get that stuff off of you as much as possible. So you change clothes, you jump in the shower, wash it off, you do a nasal rinse, get it out of your nose. And already just with a very simple step like that, you can reduce how much you are continually being exposed to for the next several hours.
Yeah. What about, I know sometimes, and I can't pinpoint why it happens to me, but I know other patients talking to me too. Like sometimes I wake up in the morning and one of my nostrils is totally clogged. What's that about?
Why? Do you flip sides to get it to open up and stuff? I often have patients.
Once I wake up and stand up, they usually clear. So then I think, oh, is my lymph's not draining? Like why is it just sitting there overnight?
Yeah.
Why won't it drain properly? And my mouth's breathing.
It's again, it's never one thing, right? So what you're feeling typically is going to be nasal congestion. And I use that word very specifically because it's usually the vasodilation, so the expansion of the blood vessels in the nasal cavity, which is a normal process that happens overnight across all of our body, right? When we sleep, all of our blood vessels actually relax a little bit and our blood pressure goes down slightly. And there's reasons for that. So that happens in our nose as well. And when the blood vessels get bigger, you feel congested, right? That's the feeling that we describe as congestion, but we're asleep for it. Now, most people aren't going to be aware of it until they wake up. But then, like you said, as soon as you stand up and you move around, your body is back to its daytime settings and you're fine. Now, a lot of people will say, it's not that quick, Dr. Lee. It takes me a good hour to feel like my nose clears out. And that's usually a combination then of other factors. So you've got the physiologic response, but then you've also got, for instance, someone who may have a dust mite allergy, and your bed is literally your hotbed of dust mite location. So you just spent 8 hours laying in all the dust mites that you're allergic to.
I should wash my sheets more often, you're telling me.
If you have a dust mite allergy, right? Not everybody does.
Yeah.
The other thing is nighttime reflux. I think people don't realize that overnight, if you have really significant reflux, the gravity is no longer helping you because you're lying flat. And that stuff can come all the way up and actually reach the back of the nose. So they've done studies to look at a specific gastric compound called pepsin. It's an enzyme. And they can find samples from the back of the nose that have pepsin in them for people that have these types of symptoms. So it tells us that reflux can reach as high as the back of your nose. In fact, this is great timing. I had a patient yesterday, and I see her for ear stuff, but she was like, do you remember when I was having that nasal congestion and like kind of headaches and just like pressure in the back of around my eyes? And she said, did you know that I finally made the connection? She had really severe reflux. She ended up having surgery, which helped her reflux. And it completely cured her nasal congestion and her headaches that she was waking up with because hers was reflux related. Mm-hmm. So again, there's a physiologic component that is somewhat normal. And then when you start adding in other inflammatory kind of factors, that's when people start to say, hang on, this is not normal.
Yeah. And I think that's true. I was thinking like this morning, I woke up congested and I'm like, what did I have for dinner last night? And my husband made this big roast, heavy protein in my meal. And I was like, I didn't take my digestive enzymes last night either. So even though I don't feel the reflux, I used to, many years ago when I was first navigating this whole alternative medicine, I had gone to an ENT because I had annoying postnasal drip. Like, he just said, let's postnasal drip. It's fine. I was like, well, why do I have it? And a lot of it was the stomach and the gut. Everything was just out of whack and out of balance. So I never had the sensation of heartburn per se, what most people feel. But I think that's really important to know that you can have reflux and you don't necessarily feel the burning.
Right. There's different types of reflux, right? You have acidic reflux, and that's what most people call reflux. That's the heartburn, that's the indigestion, that's the sour taste in your throat. And that's definitely the most common type that people think of. But you also can have non-acidic reflux. So you can have you can have gastric kind of juices coming up that are not overly acidic, but they have other enzymes in them that can still cause tissue damage up in the throat. And then you also have a connection from a nerve standpoint. So there is known connections between the nerve so this is all vagus nerve property. And when you have reflux, even into the bottom part of the esophagus, which by some cases might actually be considered normal and physiologic, it can actually cause symptoms up in your throat mediated by this nerve compound or nerve reflex. And that in the ENT world, we call this laryngopharyngeal reflux or LPRD. So add disease onto that. And that's what causes a lot of like postnasal drip, chronic throat clearing, chronic cough, maybe a little bit like of a globus sensation, like it's hard to swallow. Usually patients like that are going to notice it like a little bit worse after meals or overnight when they've been laying flat all night and they wake up first thing in the morning, especially dependent, like you said, on what did you eat for dinner the night before? Do you drink alcohol with dinner? Are you overweight? Is weight pushing up on the abdomen all night? Things like that.
Yeah, I talked to a lot of patients. The more I've seen this and tried to investigate, think a lot about of sleep apnea. I originally thought it was just an anatomic thing, but then the more of these 3D X-rays I was doing, I was like, this person has a huge airway on the CBCT, but they have sleep apnea. This person has an itty bitty airway, but they don't have sleep apnea. So it's like, okay, there's more than the anatomy. Like, what is the diaphragm doing? Just like you said, right? The breathing and the pressure differential. So I've been trying to learn more about breathing patterns and how to train patients to get that vagus Like, that is so important. Get that working properly, get the breathing properly. Breathing is the fastest way to train the vagus and to turn it on or off. I think it's interesting that you said that, because that has a lot to do with reflux. Sometimes we see, like in the teeth, they're completely eroded away from acid, but some people say, no, I don't have reflux. It could be this silent one. Or so sometimes we see that apnea with that wearing of the teeth too. And so that makes me think more of diaphragm issues, vagus nerve issues, all those kind of things. So again, looking beyond my expertise, what else is happening when you look at the whole picture together, which is, I think, really
I think there's a lot of things, and I bet you see this in the dental world too, that are, the way I describe it to patients is we're going to look at the structure and the function. And that kind of goes back to even what we talked about with tonsil stuff, right? I'm looking at the physical structures, but I'm also going to ask about the symptoms that give us a clue to more of the microscopic functionality. And you have to look at both, because if you just treat one and not the other, most of the time your patients are probably still going to have some kind of symptom that didn't get better.
That's so important. Yeah, that's what that made me think about the orthodontics again, right? So we're thinking about the structure and how the teeth look, but not necessarily the function, right? So we can then sometimes screw up all the joints and stuff because they look straight, but maybe they're not coming together exactly how all the muscles and the joints and everything want them to, and then you end up with symptoms. And if you read the fine print in Invisalign instructions, it says you'll likely need occlusal adjustment at the end. But I wonder how many people are actually told that and know to make sure. Because as dentists, we look and we're like, yeah, your teeth look great. They're nice and straight. Perfect. You're good.
Done. Yeah. Same thing in the nose, right? People do I had a patient came in today. She's like, yeah, I had a septoplasty, but I still have X, Y, and Z. And I'm like, yeah, your nose looks great. Nose is nice and straight, but she's got all this other chronic inflammatory stuff going on with her sinuses and her gut. And I'm like, that was part one. This is part two.
Yeah, exactly. So that's so important that you can help your patients in that way and say, yeah, there's a little bit more to it than that.
Yeah. And honestly, like you said before, patients are smart. People are smart, right? People know we get maybe, I don't know, I hesitate to say how many minutes I get with patients, but I often run late because I like to spend time with patients. But let's say I get 30 minutes with a patient. They spend all day with their bodies, and they've had a lifetime with their bodies. And I think that certainly sometimes people may be on the ends of this pattern, but most people are very aware of, hang on, something's not right with me. And I think you have to honor that and say, okay, I don't see anything, but let's keep looking.
We're coming up to quite that now, but I want to just touch, this is a very big topic and we could talk for probably 5 hours about it, but we hinted to a little bit about allergies. And I know that's really common for a lot of people. And there's probably no simple answer to this question. It's probably not fair to ask it. But what do you think is a lot of the root cause of allergies? Is it genetics? Is it diet? Maybe just speak a little bit about, like I said, this is a huge topic, but maybe just those people who suffer like from allergies, is there anything besides the prescription drugs and stuff like that? Is there something else they should maybe investigate?
Yeah. So that's you want the elevator version.
Yes.
Which we can do. So what I explain is allergies are an immune system dysfunction problem. That is the root cause. The immune system has somehow become hyper responsive to an antigen or a compound that it shouldn't be responding to that way. So that's the first and foremost thing. So if you go back and look at what causes immune system dysfunction, it can be a lot of different things. There absolutely is a genetic component. If you have a parent or two parents who have allergies, you are 25 to 50% more likely to have allergies yourself. Okay. So there's definitely that piece to it. But I have a lot of patients who they were fine, and all of a sudden they got some really bad viral infection, and then they developed allergies and asthma. So we know that the viral infections can change the way the immune system functions. We see that with COVID recently, but it happens for all different types of viruses too. And then when we think about it that way, I think it helps people understand that to get the most benefit from your treatments, you have to think about, is this supportive of my immune system or not? So a lot of, I think, concern is for people that this medication is just blocking my symptoms, but it's not really fixing the underlying problem. And I'm like, yeah, I agree. And some people, that is fine. Some people are saying, that's okay for now, but I want to come back later and dig deeper, and that's okay. I think that the ultimate corrective type of treatment is immunotherapy. So that is, I mean, if we want to call it something fancier, call it microdosing, right? We're microdosing your antigen that you're allergic to so that your body can learn to become tolerant to it. And that is the ultimate. And not everybody responds to immunotherapy, but for people that do, it is life changing. And those patients feel better and they don't need the medications. And ultimately, that immune system dysfunction has been in some ways corrected, right? So that to me is always an option worth talking through with people. Now, that's a big ask because immunotherapy, I will tell people, often takes about 5 years to successfully complete. So it's a big ask. So in the meantime, or for someone who's not ready to do that or can't do that for whatever reason, we do have obviously your standard over-the-counter medications. Those are going to be intranasal steroids, intranasal antihistamines, and oral antihistamines predominantly. The funny thing is, most people start with an oral antihistamine and they don't do any nasal sprays. And I will explain that if your symptoms are mostly allergic rhinitis, which is nose, you want to use a nasal spray because you're getting the medicine there fast without a lot of the systemic or full body side effects. So those are the conventional things. And then we always talk about, just like we talked about earlier with the saline rinses, we always talk about preventative measures, whether it's washing sheets weekly in hot water for dust mites and room air purifiers. So we have a lot of different things depending on what your testing shows. But that brings me to a good point. A lot of people assume that they have allergies, and we do allergy testing and it's completely negative. And then they're like, hang on a minute. Wait a second. That's also a very important piece of it because if you're taking allergy medications based on an assumption and you don't feel better, then you need to pause and think, hang on, we need to take a closer look at this because there could be something else going on. Then to move into kind of a broader integrative sphere, there are so many papers that support use of probiotic strains, use of acupuncture, use of herbal medicine, sauna. I have like pages and pages of papers that I've read through that I'm like, oh my gosh, for people that are looking for more, there are so many other options out there. And again, not everything is for everyone. Like you said, I don't tell everyone to follow the same treatment pathway because every individual is unique. But that's where you just have that conversation and you find what works for that person individually.
Definitely. Yeah, I love like being able to give the options, and then a person will usually say something will resonate with them. Oh, that's interesting, or oh, I've read about that. I've been intrigued. So that's awesome. And I often, when I think of allergies, again, I think beyond it's that whole gut, right? There's something because the immune system is right there, right? The gut, the lining thick, the immune system's right there. And we're being assaulted daily with all the toxicity in our environment today. It's not surprising that so many people have these allergies, but it's exciting to think that there is a way you can eradicate them. Some people think, I'm just going to have allergies forever. So when you were talking about immunotherapy, would it be an example of like a peanut allergy? I know I had a friend, their kid was like eating one peanut M&M so often or whatever to try to get rid of that. Do you have any inklings or maybe an answer of why that when we were growing up, nobody had a peanut allergy? Why is it that our kids' generation, why is this so prominent today?
Yeah, I think there's a lot of theories. I don't think anyone has the golden answer, but a lot of the theory is that for a little while, and this is where we live and learn, but for a little while, medicine's directive to parents was to not give their kids potentially antigenic foods like peanuts until they were older to reduce the risk of an allergic reaction. And we now know that was incorrect advice. And there were some really landmark studies that came out of Israel where they looked at kids who were fed peanut-based products at a very young age, and there was a much lower incidence of peanut allergy. And so our pediatric guidelines changed, which is appropriate. And they said, now we think you should start introducing things earlier, right? Mm-hmm. And that goes back to, remember we said tonsils are teaching the immune system. A peanut's going to pass by your tonsil, right? So the tonsil is going to take a piece of it and introduce it. Then it's going to get into the gut. And the gut lining, if it's healthy, right, which is a whole nother discussion of nutrition. Yeah. But if it's healthy, it's going to help teach the body about these different foods that we're eating, because I think the number is like 70% of the immune system cells actually live just underneath the lining of our gut. So if the gut's doing its job and if they're getting this exposure early, then and the immune system is functioning the way it should, then we don't see that progression to allergy. So I think that's a big piece of it. At least that's Monday morning quarterbacking it and saying, oh, that was the wrong advice back then. And now that's
Oh, shoot, we got it wrong. Oh, surprise, surprise.
But I think you're right. I think the modern world that we live in, no one can live a toxin-free life. No one can live a stress-free life. And it is difficult, I think, to eat in a way that is not in some way inflammatory just because of the modern world we live in the US, right? Everyone is doing the best they can. And I think the more that we as doctors and practitioners are helping and encouraging and saying, hey, did you know that maybe we could do this instead of that and it might reduce your exposure to X, Y, or Z? I think everyone's trying to move in the direction we should all move in.
Yeah. And I think patients are asking me that all the time. That's why I talk about binders a lot. I'm like, you can do all the best things, and binder minerals are so important to me because our foods have become so deficient, right? At that basic cellular level, right? We need the minerals, right? We need the vitamins, and that really is helpful. But I listened to a podcast the other day, and I'm so disappointed. I think he was a PhD scientist. His accolade, there's tons of accolades about him. He has written a ton of books, published hundreds and hundreds of papers, been cited by so many people. But he said, we don't need supplements. There's not a single study that shows supplements work. And I, like you, my mouth dropped also. And I was like,
you could see the video right now.
Yeah, I was just like, what is he? And he's on it was on one of the most popular podcasts in the world. And so I was like, this is so devastating to hear him say that. And I'm like, that's so weird because there's so much this, but he was saying, you eat well, you don't need it. I'm like, okay, but in the world we're living in today,
right?
I'm like, it was as if he was living in a bubble. And again, yes, ideally, we shouldn't need supplements. Ideally, right? Like back in the day, we got all our nutrition from our food, but that's not today's reality. So I was like, really taken aback by that comment, because I was like, no, ask any physician, anybody who's doing blood work, how deficient we all are. Why are we so chronically inflamed? Like, why is there so much chronic disease? And again, at that cellular level, it's coming down to just depletion, right? If we don't have the building blocks to create cells, we're going to manifest all sorts of things. So it's just, geez. But
it's one of those things too, where I think I don't know. I try never to make blanket statements like that because, again, every person is unique. We can talk about population-based metrics and public health measures. And in those cases, maybe you would say, oh, it's not worth supplementing, whatever. But like when you come down to an individual and you look at their individual labs and their genetics and their history, I don't think you can make that statement.
I know. I loved your reaction because I'm like, yes, that's exactly how I felt too. I was like, what is he talking about? But he's a researcher, right? So he's not with the patient. So
I'm sure he's way smarter than me when it comes to whatever his specialty is. I just think that's harsh.
Yeah, I thought I was, very surprised. But well, as we're wrapping up, Dr. Lee, is there anything else you'd love to leave the audience with? Any other tidbits or good information?
Again, this is fun. I enjoy doing this. I like just talking and collaborating. So thank you for having me. My leaving remark actually may seem like it has nothing to do with ENT, but I think that the most important message that patients can sometimes get or people can get right now is to be your own advocate, because I think the way modern healthcare runs, you get very little time with your doctor. And a lot of times that time is not allowing you time to tell your story or to ask your questions. And so I always tell people, be prepared for your visit, have your medical records on you. Don't assume that the doctor already has them. Write your questions down. And if you don't get all the questions answered, make another appointment or ask if you can message them in the portal. I think that I wish we had more time. I wish I had more time with patients. And I think a lot of doctors do. But the fact of the matter is we don't. And so I always encourage people to be their own advocate, to speak up, to get a second opinion if they feel like they weren't heard. And I think that's one of the most important things to remember.
I love it. When I would have a new patient, especially somebody like that who would come with all these questions, and it was becoming more stressful for me because all I wanted to do was sit with them for 2 hours. But we need a busy day, or like this doesn't work. So this is where I think telehealth can be great. So I started doing on Fridays, especially if it's a new patient I'm from far away. I will do a Zoom call with them, and so I'm like just totally focused on them, and that has just been such a game changer for me because it's outside of my regular clinic, which isn't feasible for everybody. And I still have the ability to do that because I work for myself, right? Sometimes in the greater medical system, that's not really an option. But hopefully, things are getting shook up a little bit and people are wanting other things. So like we said, who knows, in 5-10 years, everything's starting to look a little different. But
I love that. I think that's so great that you offer that as a service.
And it's so enjoyable for me because I really can focus and I really can be present instead of them calling me to go check this and do that or have another patient. Because like you said, so many people they want to be heard, just want somebody who will listen. And it's just the way that our modern healthcare is. Like there's just not the time because the expenses are so high and you've got to do all this and it's just too much of the business was taken out of the art, right, of medicine. So hopefully there's so many of us out there now that are, and as a patient, that's what I want too.
Absolutely.
I always think about how do I want to be treated? In my office, you can call any time of the day. Nobody is just off for lunch. That drives me crazy. When the whole office is just off for lunch and I'm like, can't you like Twitch? Or we still make personal phone calls. We have the automated system too, but still the day before. And that's not even heard of anymore.
Oh, I know. If I call a patient back, which I do a lot because I think patients want to hear from me. They don't want to hear it after it's gone through a telephone chain, right? Yeah. But people are like, oh my gosh, you actually called me? I'm like, yeah, of course I called you. And they're like, I've never had a doctor call me. And I'm like, what? This is crazy. Of course we should be calling. Yeah. But anyway.
I know.
Well, it's good.
It is a ton. Thank you so much. If somebody wants to learn more, or is there a way they could reach out to you if they had any questions?
Yeah, absolutely. I love, honestly, hearing from people and I love questions. So you can find me on social media. My Instagram handle is at ENT chat. So ENT like ear, nose, throat. And then chat is CHAT. And then you also can find my website. It's www.integrativeenthealth.com. I do have a way where people can reach out to me to see if they are interested in working together in different formats. But I also have a lot of just like blog posts, and I'm doing more and more uploads of like free kind of resource handouts. In fact, I actually have like a craniofacial growth airway one that I'm getting ready to upload. It's pediatric focused. So that'll be really exciting to have available for people too.
Great. Thank you so much for doing what you're doing. And I'm so glad the universe brought us together, and I'll have to make my way down to Charleston and hang out with your little group collaborative so I can keep learning more too.
Oh my God, we'd love to have you. It'd be great.
Thanks everybody for listening. If you have any questions, please reach out. We'll put all of those contact information in the show notes. And otherwise, have a wonderful day. We'll see you on the next episode. Hello, I'm Dr. Rachel Carver, a board-certified naturopathic biologic dentist and a certified health coach. Did you know that over 80% of the U.S. population has some form of gum disease? Many of us don't even know that we have this source of chronic infection and inflammation in our mouth that's been linked to serious consequences like heart disease, diabetes, stroke, dementia, colon cancer, kidney disease, even pregnancy complications. Would you like to learn how to reverse and prevent these chronic debilitating conditions without spending a lot of time and money at the dentist? Join me for my 6-week course where I will teach you the root cause of disease. You'll learn how to be your own best doctor. Are you ready to get started? Let's go.